Welcome to Med Simple. Today our topic is appendicitis. Appendix is the true diverticulum of the cecum that is at risk of acute and chronic inflammation, having four layers known as mucosal, submucosal, muscular, and serosal layer. The lumen is irregular, has multiple longitudinal folds of mucous membrane lined by columnar cells of intestinal mucosa. Crypts are few in number, and in the base of crypts lie the Kulczycki cells, which gives rise to the carcinoid tumors, which is their most common location. Diagnosis of appendicitis requires neutrophilic infiltration of the muscularis propria. At birth, the appendix is short and broad. During childhood, continued growth of the cecum commonly rotates the appendix into a retrocecal but intraperitoneal position. In 1/4 of the cases, rotation of the appendix does not occur, resulting in a pelvic, subcecal, or paracecal position. Sometimes the tip of the appendix becomes extraperitoneal, that lies behind the cecum or ascending colon. Rarely, the cecum does not migrate in the right lower quadrant of the abdomen. In these cases, the appendix is found near the gallbladder, or if intestinal malrotation occurs, then in the left iliac fossa, which makes the diagnosing of appendicitis difficult. The position of the base of the appendix is constant, that is found at the junction of three teiniaculi of the cecum, which fuse to form the outer longitudinal muscle coat of the appendix. By general traction on the anterior teiniaculi, the base of the appendix can be found. The mesentery of the appendix, also known as mesoappendix, arises from the lower surface of the mesentery or the terminal ileum, on which 4, 6 or more lymphatic channels traverse the mesoappendix to empty into the ileocecal lymph nodes. Appendix can have different length and circumference. The average length is between 7.5 to 10 cm. The vasculature of the appendix starts off with the superior mesenteric artery, which gives off the iliopelvic artery, which then gives the appendicular artery. The appendicular artery is an end artery, thrombosis of which results in the necrosis of the appendix, known as gangrenous appendicitis. Appendix orifice is especially important for endoscopists to confirm a full colonoscopy. Acute appendicitis is rare in infants and is common in childhood and early 20s. It is the most common extrauterine acute abdominal condition in pregnancy and the most common abdominal surgical emergency. The two clinical syndromes of acute appendicitis can be observed, which are acute non-obstructive appendicitis and acute obstructive appendicitis. If we want to find the cause of appendicitis, there is no unifying hypothesis. Decreased dietary fiber, increased consumption of refined carbohydrates, a mixed growth of aerobic and anaerobic organism is also a usual cause. Obstruction of the appendix lumen either by fecolith or a stricture, lymphoid hyperplasia, pinworm, or in elderly by tumor, particularly carcinoma of the cecum, can cause obstructive appendicitis. A fecolith, sometimes referred to as an appendicolith, is composed of fecal material, calcium phosphates, bacteria, and epithelial debris. Distension of the appendix may cause venous obstruction and ischemia of the appendix wall. With ischemia, bacterial invasion occurs through the muscularis propria and submucosa, producing acute appendicitis. Finally, ischemic necrosis of the appendix wall produces gangrenous appendicitis. Alternatively, the greater omentum and loops of small bowel becomes adherent to the inflamed appendix, walling off the spread of peritoneal contamination, resulting in a mass or a paracecal abscess. Rarely this appendiceal inflammation resolves, leaving a distended, mucus-filled organ termed as mucocele of the appendix. Classically, there is anorexia and few episodes of vomiting with central abdominal pain due to midgut visceral discomfort in response to appendiceal inflammation and obstruction. With progressive inflammation of the appendix, the parietal peritoneum in the right iliac fossa becomes irritated, producing more intense, constant, and localized somatic pain that begins to predominate, which then shifts to the right iliac fossa. Typically, coughing or sudden movement exacerbates the right iliac fossa pain. In the early acute appendicitis, there is usually a fever of 37.3 to 38.4 degrees Celsius and localized tenderness. Finding persistent guarding in the right iliac fossa on repeated examination is the key to making the diagnosis and distinguishing it from non-specific abdominal pain, which usually resolves over 24 to 48 hours. Non-specific abdominal pain does not have persistent guarding. The surface projection of the base of the appendix is at the junction of lateral and middle one-third of a line from the anterior superior iliac spine to the umbilicus, known as McBurney's point, where gentle superficial palpation of the abdomen will detect muscle guarding over the point of maximum tenderness, that is in the McBurney's point. When the patient is asked to cough or gentle percussion over the site of maximum tenderness will then elicit rebound tenderness. It occurs when the examiner palpates deeply over the right iliac fossa and the patient complains of pain when the pressure on the tender area is released. Another sign is the pointing sign, in which the patient points to where the pain began and where it moved. Rovsing sign is when the deep palpation of the left iliac fossa may cause pain in the right iliac fossa. The Swas sign is when the patient lies on the left side and the pain occurs on passive extension of the right thigh. The examiner also applies counter resistance to the right hip. An inflamed appendix lies on the psoas muscle if it is in a retrocecal position. To relieve the pain, the patient will lie with the right hip flexed. Another sign is the obturator sign. Now the obturator test is demonstrated when the hip is flexed and internally rotated, which may cause pain in the hypogastrium. It is due to the spasm of the obturator internus muscle. Now with the position of the appendix, there are some special symptoms to keep in mind. When the appendix is in the retrocecal position, rigidity is often absent, and even application of deep pressure may fail to elicit tenderness. The reason being that the cecum, distended with gas, prevents the pressure exerted by the hand from reaching the inflamed structure. However, deep tenderness is often present in the flank region, and the rigidity of the quadratus lumborum may be evident. Now, when the appendix is pelvic in location, early diarrhea results from an inflamed appendix in contact with the rectum. When the appendix lies entirely within the pelvis, there is usually complete absence of abdominal rigidity. An inflamed appendix in the pelvis may never produce somatic pain involving the interior abdominal wall. Rectal examination reveals tenderness in the rectovesical pouch or pouch of Douglas, especially on the right side, and thus is the basis for recommendation that rectal examination should be performed on every patient who presents with acute lower abdominal pain. An inflamed appendix in contact with the bladder may cause frequency of micturition. This is more common in children. When the inflamed appendix lies behind the terminal ileum, it presents with the greatest difficulty in diagnosis. Because the pain may not shift, diarrhea is a feature, and marked retching may occur. When diagnosing a disease, some differential diagnosis should be kept in mind. As in children, the disease most commonly mistaken for acute appendicitis are acute gastroenteritis and mesenteric lymphadenitis. A temperature greater than 38.5 degrees Celsius suggests mesenteric adenitis. In mesenteric lymphadenitis, the pain is colicky in nature and the cervical lymph nodes may be enlarged. In Meckel's diverticulitis, the pain is similar. However, signs may be central or left-sided. There is often a history of abdominal pain or intermittent lower gastrointestinal bleeding. Suspect intussusception when a mass is palpable in the right lower quadrant and the age is less than 2 years, as appendicitis is rare in this age. Hinoxolim purpura is often preceded by a sore throat or respiratory infection, which is nearly an ecchymotic rash typically affecting extensor surfaces of the limbs. Lobar pneumonia, the right base may give rise to right-sided abdominal pain and mimic appendicitis. In adults, Yersinia enterocolitica causes inflammation of the terminal ileum, appendix, and cecum with mesenteric adenopathy. If suspected, serum antibody titers are diagnostic. If you suspect ureteric colic, urinalysis should always be performed. Renal ultrasound or intravenous urogram is diagnostic. In perforated pelvic ulcer, the duodenal contents pass along the paracolic gutter to the right iliac fossa. As a rule, there is a history of dyspepsia and a very sudden onset of pain that starts in the epigastrium and passes down the right paracolic gutter. Testicular torsion in a teenage or young adult male is easily missed. Pain can be referred to the right iliac fossa. Acute pancreatitis should be considered in the differential diagnosis of all adults suspected of having acute appendicitis. Rectus sheath hematoma produces acute pain and localized tenderness in the right iliac fossa, often after an episode of strenuous physical exercise. Localized pain without gastrointestinal upset is the rule. In females, pelvic inflammatory disease pain is lower than in appendicitis and is bilateral. A history of vaginal discharge, dysmenorrhea, and burning pain on micturition is a helpful differential diagnostic point. Mid-cycle rupture of a follicular cyst with bleeding produces lower abdominal and pelvic pain. Right-sided acute pyelonephritis is accompanied and often preceded by increased frequency of micturition. Torsion of the ovarian cyst is a difficult differential diagnosis. When suspected, pelvic ultrasound should be done. In ectopic pregnancy, pain is severe and continues persistently until operation. In elderly, some patients with a long sigmoid lobe, the colon lies to the right of the midline, and it may be impossible to differentiate between diverticulitis and appendicitis. Abdominal CT scanning is particularly useful in this setting. Other causes in elderly are colonic carcinoma, leaking aortic aneurysm, mesenteric infarction, and intestinal obstruction. Appendicitis is a clinical diagnosis. An important tool used for the diagnosis is the Alvarado Score, in which the scoring is given to the sign and symptoms, in which 1 point is given to the migratory right iliac fossa pain, 1 point for anorexia, 1 point for nausea and vomiting, 2 points for tenderness in the right iliac fossa, 1 point for rebound tenderness, and 1 point when the temperature is raised, 2 points when the WBCs are high in number, and lastly, 1 point is for the shift to left for the neutrophil. From the total of 10, a score of 7 or more is strongly predictive of acute appendicitis. In patients with an uncertain score, that is of 5 to 6, abdominal ultrasound or contrast-enhanced CT examinations can be done to reduce the rate of negative appendectomy. Some investigations can be helpful, such as plain radiograph, that may show a calcified appendiculate in the right iliac fossa. It is not specific nor sensitive, or for children and females of reproductive age, ultrasound is done as it limits radiation exposure, but also because the symptoms could possibly be confused with gynecological disease such as ectopic pregnancy. However, the conclusive exclusion of appendicitis is dependent on the presence of a normal appendix, which is measurement of less than 6 mm in diameter. Retrocecal appendicitis cannot be detected with ultrasound, and thus CT is the next modality of choice. On CT, appendicitis is diagnosed when there is a swollen appendix of more than 7 mm with periappendiceal inflammatory change. Other signs include free fluid, thickening of the cecal pole, and right iliac fossa lymphadenopathy. Contrast CT scan is most useful in patients when there is a diagnostic uncertainty. In older patients in whom acute diverticulitis, intestinal obstruction, and neoplasm are likely differential diagnosis. Both CT and ultrasound can also identify lesions if an inflamed appendix rupture, and percutaneous drainage can be done before the final surgery is performed. The traditional treatment for acute appendicitis is appendectomy. It should be performed under general anesthesia with the patient lying supine on the operating table. Also, an appendix removed for appendicitis could contain an incidental carcinoid tumor. Tissue analysis also helps to determine treatment and prognosis. Conservative approach should be considered in patients with high operative risk and in those thought not to have obstructive appendicitis, in which bowel rest and intravenous antibiotics, usually metronidazole and third-generation cephalosporin, and IV fluids to maintain adequate urine output are initiated. Operations shouldn't be postponed for longer than necessary to improve the patient's health after acute obstructive appendicitis is identified. Having said that, if not treated immediately, an abscess formation may occur. Pelvic is the most common site of abscess formation, which is an occasional complication and can occur irrespective of the position of the appendix within the peritoneal cavity. The most common presentation is a spiking fever several days after the appendicitis. If an appendix mass is present and the condition of the patient is satisfactory, the standard treatment is the conservative Ochsner-sherren Regime, the basis of which is that the inflammatory process is already localized and that unplanned surgery is difficult and may be dangerous. It is helpful to mark the limits of the mass on the abdominal wall using a skin pencil. A contrast CT examination of the abdomen should be performed and antibiotic therapy should be started. Temperature and pulse rate should be recorded 4-hourly, and fluid balance record should be maintained. The clinical improvement is usually evident within 24 to 48 hours, and an interval appendectomy can be considered 6 weeks later. Conservative treatment should be stopped for an appendix mass when there is a rising pulse rate, increasing or spreading abdominal pain, increasing size of the mass. Peritonitis occurs as a result of free migration of bacteria through an ischemic appendicular wall, frank perforation of a gangrenous appendix, or delayed perforation of an appendix mass. Certain risk factors for the perforation of the appendix are extremes of ages, in which many patients under the age of 5 present with the perforated appendix because the omentum is less well developed and the inflammation is not well contained. Other risk factors are immunosuppression, diabetes mellitus, and fecolate obstruction of the appendix lumen, a free-lying pelvic appendix, and a previous abdominal surgery that limits the ability of the greater omentum to wall off the spread of peritoneal contamination. The treatment starts with resuscitation with intravenous fluids, analgesia, and broad-spectrum antibiotics. Appendectomy can be performed laparoscopically. This concludes the video. Please feel free to comment on next topic and subscribe Math Simple for more lectures. Thank you.